Awesome. We're so happy to have so many people joining us this afternoon on our third webinar during our Black Maternal Health Week campaign and celebration. So definitely we want to say happy Black Maternal Health Week to everyone. So we're going to go ahead and get started. So good afternoon, everyone, once again, and thank you for joining us for today's webinar entitled Improving Health Outcomes for Black Mamas Through Holistic Midwifery Care, as presented by members of the Black Mamas Matter Alliance for our third annual Black Maternal Health Week campaign. My name is Angela Doinsala Aina, and I am the current interim executive director here at the Black Mamas Matter Alliance. Before we get started, I would like to cover some logistical items. Everyone is currently muted and will stay muted during the webinar. We will have time at the end for questions through the chat box, so feel free to submit any questions that arise throughout this webinar, and we will try our best to address them after the presentation. Please note that all webinars presented this week will be recorded and available for your viewing on our website. I want to take a moment to express our deep gratitude to all of this year's Black Maternal Health Week sponsors. We'd like to give a special recognition to our change maker level sponsors, the United Way of Greater Atlanta and Merck for Mothers, and our movement builder level sponsors, City Match, Every Mother Counts, Vintner's Daughters, and the American College of Obstetricians and Gynecologists. Your investment in this campaign continues to help us make a significant impact. So a little bit about us. The Black Mamas Matter Alliance is a national network of Black women-led organizations and multidisciplinary professionals that work across the full spectrum of maternal and reproductive health. We operate at the national, state, and local levels and collaborate to advance policy, promote holistic maternity care, cultivate research, and uplift culture to advance Black maternal health rooted in birth and reproductive justice, respectful maternity care, and the human rights framework. Of particular note, we use the phrase Black mamas to include a range of folks, from women and birthing people across the African diaspora to those who care for and mother our families and our communities, whether they have given birth themselves or not. Founded by the Black Mamas Matter Alliance, the National Black Maternal Health Week campaign intentionally takes place in April, which is recognized in the United States as National Minority Health Month. Additionally, we begin Black Maternal Health Week on April 11th annually to join dozens of global organizations in marking this day as the International Day for Maternal Health and Rights, an opportunity to advocate for the elimination of maternal mortality. For BMMA, we recognize maternal mortality as a global crisis affecting Black women across the world, not just in the United States. And we join other Black and African women leaders across the diaspora in the fight to end maternal mortality. The purpose of Black Maternal Health Week is to deepen the national conversation about Black maternal health so that public stakeholders understand how root causes like structural racism and gender oppression act as drivers of maternal health disparities. This year's theme is Centering Black Mamas, the Right to Live and Thrive. Centering Black mamas and their right to live and thrive highlights the need for health practitioners to listen to Black mamas in their care and service provision. This is especially important now that we have better data that provides further evidence that the lack of quality of care and disregard for Black women's humanity is deadly. By centering community-driven solutions, such as what we're going to talk about today, we can help Black women, their children, and their families thrive. Here at the Black Mamas Matter Alliance, we honor, uplift, and celebrate the historical and ongoing contributions of Black midwives who provide holistic and respectful reproductive health care to Black mamas. In February of this year, our community lost Grand Midwife Mama Claudia Booker. As a licensed midwife, she founded Birthing Hands of DC and served birthing mothers and families in the Washington, DC, Maryland, and Northern Virginia areas. Mama Claudia Booker was a fierce advocate, a mother, an educator, a mentor for many of the midwives in our alliance, and a philanthropist. In 2018, she was honored along with 15 other Grand Midwives at BMMA's Black Maternal Health Conference and Training Institute for their contributions to Black maternal health rights and justice. Just before her transition, she made a beautiful donation to sponsor this year's Black Maternal Health Campaign. We are forever and eternally grateful for her love, her wisdom, and legacy. Mama Claudia Booker, may you continue to rest in power. We will now transition and hear from some incredible and dynamic Black midwives in our alliance. Starting off today's webinar is Jamira Amani. Jamira is a community midwife who believes in the power of birth and that every baby has a human right to be breastfed and chest fed. Her mission is to do her part to build a movement for birth justice locally, nationally, and globally. She is currently the director of the Southern Birth Justice Network, a nonprofit organization working to demand dignity for pregnant and parenting people and to make midwifery and doula care accessible to marginalized communities. And she also serves as the co-founder of the National Black Midwives Alliance. We welcome Jamira Amani.
Thank you, Angela, for that introduction, and greetings, everyone. I also want to thank you for the tribute to Mama Claudia. That was really beautiful. So I am a midwife, and I am going to be talking today about birth justice and the struggle for healthy communities. So let's jump right into it. In order to talk about birth justice, we have to talk about power. Next slide, please. So we're going to talk about power disparities. There we go. So according to the Fanon Project, power disparities are the observable and unobservable differences in access, opportunity, and participation. We know that power is not individually based, but it's inherently collective. So when we talk about power, we have to talk about community. We have to talk about the collective. And then we experience power dynamics within our society's institutions. And my favorite epidemiologist, Dr. Kamara Phyllis-Jones, talks about health equity as a discourse about bodies that necessitates critical and intersectional analysis of relational power dynamics. And we know that these power dynamics are historical. They were not dropped out of the sky or created in a vacuum, but they are connected to the lived history of peoples, the collective history of peoples. And they continue to shape our experiences, our exposures, and our opportunities. Next slide. So I was asked to speak today about the root causes of maternal mortality. So in general, root causes of health disparity relate to three major areas, which is what people experience, the quality of care they receive within the healthcare system, differences in access to healthcare, including prevention. So everything from the cradle to the grave, including prevention and different levels of access to healthcare. And then also differences in life opportunities, exposures, and stresses that results in differences in underlying health status. And that's also referred to as the life course perspective. Next slide. So we know that power disparities lead to health disparities. We actually, in order to have a responsible conversation about health disparities, we do have to talk about power disparities. Next slide. And we know that increasing the power of the people most impacted by health disparities is how we improve health outcomes. So having conversations about improving health that doesn't involve how we impact and increase people's power is an incomplete conversation. Next slide. So what are the factors that we're talking about when it comes to the root causes of maternal mortality? So we're talking about the stress of racism. We're talking about the lack of access to care or the quality of care, the lack of follow-up. So for example, the glaring lack of postpartum care that exists within our healthcare system, the lack of education about options and about potential risk factors and complications, the lack of accessible information, and the other side of that is information overload. So you can Google everything and still know nothing. And because that information is not really contextualized. And if people don't have basic comprehensive information about their bodies and how they work, then it's going to be difficult to contextualize information, even if you can Google preeclampsia or any other health issue. So it goes back to, what knowledge that we have about our bodies in general and what access to information people have. So also culturally and racially inappropriate care, institutional bureaucracy that impedes access. I love call and response, and so I'm glad I see folks introducing themselves. And I would also like to know what are some of the factors that you've identified in your work. If you're a midwife or a birth worker or a social worker or whatever work that you do, what are some of the factors that you are seeing? Please drop it in the chat so that it's more of a conversation. I'd love to hear from you. Previous birth trauma is a major issue when it comes to maternal mortality. This is something that I see a lot as a midwife. People carrying the trauma from previous birth experiences and how that impacts, how they experience their next pregnancy or their next birth. Intersecting oppressions. So we're not just Black, but we're Black women. And then there are some folks who are also Black and transgender, Black and poor, Black and an immigrant, and many, many intersecting oppressions. And the more of those oppressions that you are experiencing, the heavier that social burden is going to be on you and impacting your health outcomes. And then other social stressors, and we can go on, and I see them coming in. Thank you all so much. I feel affirmed that and heard that I put out a question and I'm getting some answers. Thank you so much. Next slide, please. So furthermore, the root causes of Black maternal mortality specifically relate to white supremacy and how privilege defines the education of healthcare providers and access to healthcare systems. Also, structural and institutional racism are pre-existing conditions, and we need to really talk about them in this way. Pre-existing conditions are really talked about in very medical terms, but these social factors are pre-existing conditions. And we're seeing that right now with the coronavirus COVID-19 pandemic and how it's disproportionately impacting Black folks. And that is 100% because of structural and institutional racism. And Black maternal mortality is the same. So also the child welfare and healthcare systems still operate on the 1965 Moynihan Report, which blamed Black women for our social and economic status. Our systems have not really changed much or been updated since that era when everything that was considered wrong in the Black community was blamed on Black women. And in fact, pathologizing of Black women's bodies and lives is the norm. And Black people's bodies and lives are only considered valuable to the extent that they perpetuate capitalism. And so until we understand and are able to articulate and create policy around our inherent value, it is going to be very difficult to shift some of these disparities. Next slide, please. So what is birth justice? Birth justice is a framework that was developed in 2010. Can't believe it's been 10 years. We did the first Birth Justice 101 at the US Social Forum in Detroit. Holla out to anybody who was there. And it was developed to address the root causes of birth disparities. Birth justice recognizes that all people can birth and be parents, people of color, immigrant folks, LGBTQI plus communities in particular have survived a history of trauma and oppression around our decisions to have and to not have babies. Birth justice is intersectional. It engages pregnant and parenting people to participate in actions to address health and power disparities in their own communities. And birth justice is bringing midwifery care back into our communities because we know that midwives save lives. Next slide, please. So some of the key issues in birth justice, I'll go through these quickly so you can go ahead, thank you. Reducing maternal and infant mortality, health disparities as human rights violations, stopping the shackling of pregnant people, improving access to the midwifery model of care, access to tools for self-care, and community-based, humanistic, trauma-informed care, and that all of these are human rights, right? And that not having access to these things is actually what is creating the health disparities and perpetuating them. Increasing the numbers of providers of midwifery care from marginalized communities, the right to VBAC, the right to breastfeed, the right to mother and parent, expanding the right to terminate a pregnancy, uplifting consensual pregnancies, and access to termination when pregnancies are either not wanted or non-consensual, the right to access holistic and natural care options. And this list is not exhaustive. We made a list last year of the birth justice agenda and all of the key issues, and there were over 40 issues. So this is just a sampling of some of the key issues in birth justice. Next slide, please. So recently we released at Southern Birth Justice Network in collaboration with National Black Midwives Alliance, the Birth Justice Bill of Rights. You can find this on our website, southernbirthjustice.org. Also, there's a second document which explains each of these points in more detail. But this is just an overview and a tool for advocacy, for education, and for policy change. As we are moving into a time where there are more restrictions on birthing people, in particular in hospitals, it's important that folks know what their rights are and be able to advocate for their rights. And that hospital, facility, and legal policies, federal policies, state policies, local policies reflect what our rights are. And that these are inalienable rights, these are human rights, these are natural given rights. Just the fact that we live and breathe means that we should be able to have our values, our culture, our identity, our Blackness, our right to safety from violence, our families, our support networks, and all of that respected, and that we should never have to surrender our bodies to the system. Next slide, please. So we're going to talk a little bit about out-of-hospital birth. And I just wanted to uplift that home births are for Black families. That is not a message that we hear often. There has been a shift in midwifery over the last few decades from being a community-based tool and access and healthcare right to also to being more seen as a boutique service for wealthy, educated, predominantly white families. And so part of the work of building a birth justice movement is to shift the narrative back to centering Black families. So home births are for Black families. Next slide. So right now, in the midst of the COVID-19 crisis, we do have an increase in demand for out-of-hospital birth. Some of the concerns that I'm hearing from birthing people are that they do not want to be separated from either their baby, their partner, or their doula, which is one reason that people are choosing to birth out of the hospital. There have been some scenarios where people are being separated from their babies either as routine policy or as because of suspected COVID-19 testing or suspected COVID-19 infection or being in the midst of being tested and waiting for test results and separation occurring during that time period. There have been situations where people have been separated from their partners, and also the majority of hospitals right now are not allowing doulas to come in. And so those are some reasons that people are moving to out-of-hospital birth, because separation is traumatic. And increasing induction rates and in surgical births. I've been hearing anecdotally a lot of stories of people being told by their doctors that they needed to be induced because they don't want the hospitals to become too full. And we know that induction also leads to higher C-section rates. And so that is a concern. Also fears of exposure to coronavirus. Being a low-risk, healthy person, a lot of folks are asking the question, why should I go to a hospital where there are sick people? And that is always the question when it comes to deciding between a hospital and out-of-hospital birth, but I think that that is even amplified with the current situation. Also fears of their rights being denied. We know that in situations of pandemics and crises, people with already tenuous rights have even less access to their rights. Some of the concerns I'm hearing is that people are having a hard time finding a midwife, and in particular, finding a Black midwife. I get several calls a week of people looking for a Black midwife. Folks are also concerned about risking out, being post-dates, which means after 40 weeks. Having a breech baby or having twins also increases the likelihood of a C-section. Comorbidities that people are experiencing, higher stress levels, including partner violence as people are forced into quarantines and not necessarily safe situations, increasing financial and family stress, access issues. So folks are switching their care from a hospital to a birth center or home birth. There are cost factors that are involved. Not everyone is in a place where home birth or birth center birth is covered by insurance. Also transportation, especially my young mamas that I work with, their families really rely on 911 and the ambulance system, EMS, to transport to hospital in the case that is necessary if someone's in labor. And so that doesn't exist for, out of hospital birth, well, particularly birth centers. Medicaid and insurance coverage is something we need to be advocating for, that it's covered for everyone everywhere to have an out-of-hospital birth. And then also another thing that I'm seeing a lot is addressing fears. People are coming into an out-of-hospital birth situation with a lot of fear, particularly people that are transferring late in pregnancy in the third trimester and trying to get in all the education around natural birth and what does it mean to have a home birth just in a short time, in a few weeks. Next slide, please. So a couple of weeks ago, we had a Black Midwives town hall. National Black Midwives Alliance hosted it. And these are some of the issues that came up that midwives are facing and dealing with. So I just wanted to highlight these. So there right now is an Acog recommendation to find innovative ways to collaborate with midwives. And Acog is the American College of Obstetrics and Gynecology. And it's interesting that Acog would recommend that. And it feels like a step forward in some ways, in the sense that there is kind of a dynamic between doctors and midwives that isn't always friendly. So the directive to find ways to collaborate just shows you how overwhelmed our healthcare system is, and also highlights that we need to make sure that midwives are licensed and certified in all the places where they practice so that they're not facing increasing criminalization or legal repercussions from trying to be a place that receives the overflow from hospitals. We need to increase the midwife workforce. We need more midwives, we need more midwives, we need more midwives, which means increasing access to midwifery education and practicum for midwifery students, so preceptor sites that have midwives of color that are welcoming, that welcome queer and trans midwives as well, student midwives, because safety has been an issue. Cultural safety for student midwives is a major issue in finding preceptor sites. We also need more training for assistants and support staff that work with midwives. I'm hearing a lot of folks saying that they are overwhelmed by the influx of clients coming in that want to birth out of hospital. There are administrative needs associated with that, such as billing and intake forms, and just making sure that families have what they need as they transition to out-of-hospital settings. So it's not just more midwives that we need, but we also need more support staff that can work with midwives. Midwives are utilizing telehealth on a larger scale now. So that means, FaceTiming, WhatsApping, using various systems to interface with clients in a way that is not in person to reduce exposure. So we're seeing a lot more of that. We need more sustainable and fair compensation for all of this. Many midwives are bartering. Some are reducing their rates. Some are doing sliding scale. Some are doing pro bono births, just so that they can make midwifery accessible in their community. I know at Southern Birth Justice Network, we are a 501c3, we're grant funded, and so we're able to do sliding scale and make some of our services accessible to folks who might not otherwise be able to afford them. But really, our government needs to be responsible for making sure that people have access to midwifery care wherever they are. And so some of the midwife practice considerations that are coming up: access to personal protective equipment. Of course, we hear this a lot in the media. Midwives are also dealing with this, and a lot of times making our own and getting really creative on our sewing machines, and putting together whatever we have at home, wearing ponchos to births, so that we can have some level of protection. Also, there's changing guidance on water birth. Some people are not doing it at all because of the risk factors associated with the transmission of coronavirus through fecal matter and how that shows up in water birth. Others are putting bleach in the water, or peroxide, or other things that can kill the virus. So there's a lot of discussions going on within the midwifery community around best practices, but there's a lot changing with access to water birth too. Screening for risk factors is really huge. With out-of-hospital birth, of course, we want to care for people who have low-risk pregnancies, and are able to have a relatively normal, what we call uneventful delivery. And so that screening piece is really important. And when you're getting an influx of people coming in, particularly at the end of their pregnancy, when you might not have been able to have as much of an influence on their emotional state, their diet, their nutrition, and the type of holistic care that midwives provide, it can be really challenging. And then, of course, going back to what I shared earlier about staffing capacity issues, a lot of midwives that we're hearing from are feeling incredibly overwhelmed and needing to either double their staffing capacity or outsource things so that they can be more present with the numbers of clients that are coming in. So next slide, please. All that being said, I encourage you to join the movement, get involved in figuring out how to support midwives. National Black Midwives Alliance exists to raise awareness about Black midwives, to help eliminate disparities in the US, to support legislative efforts led by Black midwives and allies, and to advocate for educational pathways for Black student midwives. So if you're not a member already, please join at blackmidwivesalliance.org/membership. And we do have ally membership. So even if you are not Black or not a midwife, there are ways for you to support this movement. And with that, I am complete. Thank you so much.
Thank you so very much for that, Jamira. We really do appreciate you so very much. Next, we will have Jenny Joseph. Jenny is a well-respected health advocate for women and newborn babies. A British-trained midwife, Jenny has become one of the world's most respected midwives and authorities on women's health, healthy pregnancies, healthy deliveries, and healthy babies. Jenny is the founder and executive director of Common Sense Childbirth Incorporated and the creator of the JJ Way, a common sense approach designed for women and children. She is also the founder of the National Perinatal Task Force. We welcome Mama Jenny Joseph.
Thank you so much, Angela, and thank you, Jamara, too. And especially thank you for that beautiful tribute to Mama Claudia Booker. It has gotten me quite moved and riled up already, and I haven't even started, but I want to very quickly just run through some of the history. And this is a set of slides that Claudia Booker and myself and Aisha Curry Ibrahim worked on many, many years ago. And Claudia was so proud and was very keen to teach from these slides. And there's some of these pictures are here. Angela, you can keep scrolling. That just were, she wanted to make sure we knew and understood our history as Black midwives in the United States. So from enslavement onwards, Black women have delivered America, both Black and white babies, along with indigenous midwives. Midwifery was how you had a baby. Midwifery still is how you have a baby in the rest of the entire world, but not the United States. Unfortunately, we have a very nasty legacy. Gynecological torture. Many of you know about the experimentation on enslaved women, particularly on gynecological surgeries, fistula surgeries. Women were forced to suffer horrendous and outrageous treatment. They were left with wounds unhealed. They were put back into, childbearing. They had all kinds of criminal and horrible, horrific tortures in order for white gynecologists and slave owners to learn. But midwifery was always a main staple. And through the empirical handing down of knowledge from mother to daughter, aunt to niece, grandmother, we shared our knowledge and grew the practice and managed to serve vast numbers of women and serve them well. Angela, you can keep scrolling. So these are some pictures here of midwives from Virginia. Midwives, especially what we now call grand midwives, but they were referred to as granny midwives, were well known in every community and supported every community. Many of them were, just complete heroines to their neighborhoods and their communities. Everybody knew how to find the midwife. Everybody knew who she was. And she didn't just do maternity care. Much of the nursing, taking care of the elderly, taking care of the children, that was the midwife's purview. And she was respected and honored throughout these communities for centuries. Go ahead, Angela. So here's midwife Mariah Watkins, who delivered George Washington Carver. You can see the pride and the autonomy that midwives have had because of their art, because of their skills, because of their compassion and their ability to do what they do so well, safely. And so you see that the midwifery was really a main staple throughout the United States until such time as it became a commodity that was to be commandeered. Around the early 1900s, about 50% of births were delivered by midwives, and of course, babies were delivered at home. And that changed drastically. Next slide, Angela. And so what we saw was that there was a sudden interest in taking over and making money delivering babies. American midwifery didn't disappear, it was racialized. This was about race and power. The 1921 Shepard Towner Act was an act that was put in place where after white middle-class women, northern women were sent down to the southern states to do surveys and to gather data, they were able to come back with the idea that, what was really wrong was that the Black midwives were dangerous and were causing harm and were the reason why the infant mortality and maternal mortality rates were so high. So we have to recognize that there was a definite effort, a distinct effort to make this change. And money came right behind it. This was, go ahead, Angela, this was when public health nurses were deployed, often from the northern states to the south, to educate and support and to change midwifery and essentially to eradicate midwifery in order to address and supposedly fix the problem. Go ahead, Angela. So in this instance, you see a public health nurse, a white public health nurse in the South trying to, support families. But essentially what they were also doing was training or supposedly training midwives who had been practicing for decades and who knew very well what to do, and oftentimes ended up training them. Go ahead, Angela. So some of these midwives, for example, Aunt Sally from Gee's Bend in Alabama, she was the only medical person in her area. Mama Lou delivered babies in Georgia. Many of the midwives had many years of service. They may have delivered their entire adult life. And, when they passed, they were probably still, prior to dying, they were still delivering. But they were forced into classes, into institutes, under the auspices of the departments of health and the public health nurses in order to be trained and then also to be certified such that then they could then be decertified. Their licenses were taken. Go ahead, Angela. And so you begin to see the schools of nursing and the schools of midwifery to begin to develop. Angela, keep going. And so you'll see that as we go through into towards the second half of the late century, that it became a normal thing to certify midwives who formerly had been working independently and who had to have certain restrictions. They had to carry a bag. They had to have certain things in the bag. The bags were inspected and passed. So keep going, Angela. At the time, here's an example of Florida when they were given a license, but then the honorable discharge came right behind it. In other words, now stop. Don't do what you're doing anymore. This is an example of what was needed in the bag that had to be inspected and passed. And of course, Black midwives were not that bothered about that. They had secret compartments in their bags. They had ways to continue to do the things that traditionally they knew to do and had been doing. Mamie Odessa Hale was a very important midwife. She worked for the county, this was Arkansas, I believe, and she started training Black midwives as a Black nurse midwife herself. And this was the beginning of when nurse midwifery became a new thing to do. Go ahead, Angela. So many of you may have heard of midwife Maud Cullen, a very famous nurse midwife who served in Florida and I believe Georgia. Keep going. And you see her here taking care of children as well. They often were taking care of the entire family right through to elderly, as I said before. And Miss Mary Frances Coley was featured in a film, All My Babies, in 1952. And then there was the amazing Margaret Charles Smith, such a powerful woman. Some of us were blessed to have been able to spend time with her, and she has now passed on. But what an amazing woman. Keep going. Thank you, Angela. Gladys Milton was a Florida Grand midwife, and I had the pleasure of meeting her and having time with her, which I cherish. Her daughter, Maria Milton, continues that birthing center up in the panhandle of Florida to this day. And here's Maria, Gladys's daughter, still delivering babies, still running the birth center, one of the earliest birth centers in the state of Florida. Sandra Abdullah Zaima Salama, who was at the farm at the time and inspired so many of us. She still, to this day, is active in Georgia and such an inspiration to us all. So keep going, Angela. So these are the midwives who started organizing back in the 80s and 90s, maybe a little bit earlier actually. And you see Salama again, there's Mama Ayana, who has passed, and Mama Makeda, who is now in the Virgin Islands. Amazing midwives, such heroes to us all. And keep going, Angela. Mama Shafia Monroe, of course, the founder of the International Center for Traditional Childbearing. And Mama Shafia is getting all emotional. Just keep going, Angela. So some pictures of and the earlier times. These were the midwives beginning to form, organize, pull ourselves together into groups. ICTC was leading at the time as far as the groups of midwives that would meet. Keep going. And so into the 21st century. And of course, I'm not going to stop here because I want to cover a little bit more about what we're doing currently. But now midwifery is sort of, as it does, comes full circle. And we are here to serve our communities, whether nurse midwifery, certified professional midwives, apprentice trained, direct entry midwives, community midwives, traditional midwives. We have so many routes to midwifery, but we need so many more ways, and we need to expedite training and certification of African descent midwives who can serve communities of need and who can be able to have autonomy and the power that they so deserve back again. Go ahead, Angela. Another picture of some of us at earlier times. And if you keep going, this is one of Mama Claudia's pictures that she had for many years in her home. And these are some of the organizations. I'm going to keep going because of time. And I apologize that I'm going so fast, but I just want to cover some other points. So we know, obviously, historically, then and now, midwifery transforms communities. The next slide, Angela. Not only in the sense of providing that support, which is critical to health and well-being, but also in terms of the actual outcomes. If you think back to those early days in the 20th century, their whole purpose, or the pretense at least, was, we're here trying to save and change these outcomes. Well, not a whole lot has actually changed. We have woefully horrendous and egregious birth outcomes, such as low birth weight, prematurity, and for mothers, of course, the mortality and morbidity, where our mothers are lost through lack of care. It's not just physiology that is killing babies and mothers. It's racism, it's classism, it's sexism. These are the root causes, structural and institutional racism. That is what we have to address. That is what we have to acknowledge. It's time to tell the truth. Angela, go ahead. So I created a model. I called it the JJ Way, which was just a silly name I came up with, but really it's nothing more than a midwifery model of care. And really the premise was this: could you just create a culture and an environment that supports all pregnant women? And if you could, would that make a difference between their health and the gestational age of their baby and the birth weight of their baby and the breastfeeding? Could that happen? So go ahead, Angela. Well, it's not that complicated, because we just stood with this vision. If all women have access, if they have the connections, if they have the knowledge and the empowerment necessary to achieve their healthiest pregnancy, they will thrive. Angela, go ahead. So it basically came up out of that. Midwifery care, providing patient-centered, woman-centered, family-centered, culturally congruent, respectful maternity care with the social support is the key. We don't need a study. We don't need any more medication. We don't need any more foolishness. We just need to get to it. And until we do, we won't see the change. Because when the grand midwives, the enslaved midwives, the indigenous midwives, when the women were supported by the women who knew, they were safe. The four cornerstones of my model of care, the JJ Way, is access, connections, knowledge, and empowerment. I have a birthing center in Orlando, Florida, and I have what I call the Easy Access Clinic as well, where we provide prenatal care and postpartum care in the same way that I've just described for women who are still choosing hospital birth because that's where they want to be and that's where they feel safe and because they get to choose. So we provide care. And what we found in offering that opportunity has been that we have seen volumes and volumes of women. Since COVID-19 hit, we've had to really downsize and figure out what we're doing. At that point, we had 180 patients on board who are having prenatal and postpartum care in this model of care and doing amazingly well in hospital environments because they know how to fend for themselves. They know how to fight for themselves. They know what they want. And that's what I'm talking about as far as how community midwives can impact on broader levels because not everybody wants a home birth, not everybody wants a birth center birth, but what we really want is to have everybody have their choice. Angela? So these are the possibilities that we see with this model. These are the opportunities, and this is what we want to grow. This is why we need more midwives. We can provide those clinical services, the usual prenatal, postpartum, preconception, family planning care, but we also are able to triage women who might be heading into riskier waters and get with them sooner and mitigate so many of those risks by referring to high risk where we need consultations, collaborating with hospital systems when we need them, and doing the health navigation that no one else wants to do. Midwives will do health navigation in order to make sure that their clients are thriving. Then there's birth center options, community birth centers for low risk full-term pregnancies, natural birth options with midwifery and doula support. But as I said, the hospital also can work if you prepare, if you support, if you empower mothers and fathers, families to do what they need. And then, of course, the outreach care, home visiting, clinic-based support, support groups and mentoring, community-based doulas, breastfeeding, peer counseling and support, all the things that we all know. This is why I call it common sense childbirth, Angela. So reality check. Let's think about what we're doing here, because anybody can run a community-based maternity medical home. Any willing provider, as long as you're maintaining the midwifery model. The midwifery model is the key. So we need to look at what we can do about disparities. What does it cost? Who are our real allies and how are they supporting? The workforce needs to be developed. We need to grow midwives. We need to grow community providers, health workers, doulas, anybody, any willing person who wants to address disparities. We need to support the growth and development, get them in the pipeline. Who knows where the career path will lead them, but we have to get started somewhere. We have to look at sustainability and capacity, but the ultimate goal is transformation. Angela. If you haven't seen, there's a really great TED Talk by Miriam Zoila Perez, an amazing journalist who talks about how racism is the problem. It's important that we keep focused on what's for real. Go ahead, Angela. The New York Times covered some of our work and again pointing out that making it safer for women, it still comes down to these same four tenets: access, connections, knowledge, empowerment. Angela. So the National Perinatal Task Force was grown and developed off of this idea of when not only must we support families, mother, baby, father, family, and center them, we must also, in order to continue to center our communities, look after ourselves. My colleague Paola Rojas and Becky Duncan and Ishe Cole, we worked hard to create this task force. And the basic work is building a movement to birth a more just and loving world. This is about power. This is about justice. This is about making a change, a transformation that will save lives. We encourage anybody to look into our work at the task force by going to perinataltaskforce.com. Angela. And lastly, this is the message. Until we listen to women, we cannot do anything that will make a substantial change in their outcomes. Listen to women. Listen, because not listening is a matter of life and death. And thank you so much for the chance to speak today.
Thank you so very much, Mama Jenny Joseph. We really do appreciate it. And we thank you, we thank Jamira, and we also thank all of our midwives on our webinar today, because as you all know, because we see the beautiful, wonderful comments in the chat box, but of course, as you all know, these midwives are also practicing. So, you know, we always ask for people to continue to lift each and every one of them up for more blessings. Thank you so very much for that powerful presentation, Mama Jenny. Our next presenter is Dr. Makea Grayson. Dr. Grayson is a nurse midwife at Choices Memphis Center for Reproductive Health. With a strong background in anthropology and nursing, Dr. Grayson worked in public health, where she studied and developed community programs centered on HIV and reproductive health. While working on an infant mortality community project, She saw a great need to address maternal and child health and decided to become a midwife. Dr. Grayson joined the staff at Choices in June 2017 and is bringing midwifery and full spectrum comprehensive reproductive health care to families in Memphis, Tennessee. We welcome Dr. Grayson.
Thank you, Angela. Thank you for that introduction. And definitely, again, thank you for the beautiful tribute you gave to Mama Claudia at the beginning of the presentation. I'm just going to talk for a little while about what we're doing here in Memphis and talk about the comprehensive reproductive health care model and why it's important to our community. Next slide. I saw this quote and I thought that it was so timely and perfect. It says, one of the darkest moments in US history was the systematic eradication of the African-American midwife from her community, resulting in a legacy of birth injustices. And of course, Mama Shafia was the one who stated that, and she was so right. And so you heard the history from Jenny, and I'll touch upon it a little bit, but not much, but I'll talk about it a little bit. Next slide. One of the things I wanted to talk about was, in talking about the history of midwifery and the grand midwives, we have to also remember that they were seen as, caregivers and healers, and not only just provided care in terms of prenatal care and birth, but they also provided care in terms of abortion care and helped families who were not ready to have more children. And so this is one of the really important things that I think that we kind of leave out of the history, and that it was an anti-abortion, anti-midwifery, anti-homeopathic movement in between 1880 and in the 1920s, and that physicians really began to attack midwives, not just because of the care that they were providing in terms of prenatal care, but also the care that they were providing in terms of abortion care. And of course, this severely hurt and marginalized poor communities, leaving them with no access to prenatal care or abortions. Next slide. This is a picture actually that one of my student midwives found of midwives, Black midwives. It was taken actually in Shelby County, Memphis, which is in Memphis, Tennessee. And this is maybe, I'm not sure if this is the last one, but this is one of the last pictures that they took together when they came together to have their, their check off of their skills at the health department. And so when she found this picture, I thought it was really important to put it here and to lift these women up, because none of them are honored in the ways that they should be. And presently in Memphis, there are no Black home birth, certified professional midwives or direct entry midwives. Next slide. So Memphis, Tennessee, which is located in the far southwest corner of the state, which we're bordered by Mississippi and Arkansas. In Memphis has a population that is 65% African American, and the poverty rate is 26.9%, with the Black poverty rate being 34%. And more than 50% of the pregnant people in Tennessee are on TennCare, which is our local state Medicaid. 78, we know that we had 78 pregnant people to die in 2017, and that the infant mortality rate in Memphis right now is about 9.6. Memphis used to have the highest infant mortality rate in the country at one time, and presently it's at 9.6. One of the things that is plaguing Memphis is that many of the providers in Memphis have fled the city to more affluent suburban communities, which has really left a lot of people who are in the inner city with few options in terms of providers. Next slide. Memphis is, like I said, we've had the highest infant mortality rate at one time that that there was a documentary done called Babyland to talk about this cemetery here that actually every Tuesday, I believe it is, that they go and bury all of these babies. Also, Tanya Lee, the wife of Spike Lee, did a documentary called Crisis in the Crib, Saving Our Nation's Babies, about the infant mortality that Memphis was experiencing because it was so high. Next slide. So, which brings me to Choices and the work that we do and how we came to do this work. So, Choices is a comprehensive reproductive healthcare center that was started in 1974, right after Roe v. Wade. And when it was initially started, it was a first trimester abortion clinic. It was always a nonprofit clinic, but it was a first trimester abortion clinic that was cash pay and only had one part-time physician. Next slide, please. Now today, Choices, this is the top picture is our present building. The bottom picture is our new building that is, that we will open in June of 2020, which will be a 16,000 square foot birth center. We will be a comprehensive reproductive healthcare center. We will have all our services there. Presently, we are still a 501c3. We do accept Medicaid, private insurance. We have one full-time OBGYN, 2 full-time certified nurse midwives, 1 full-time certified professional midwife, and we have a new certified midwife who is coming on and starting in June 2020. I'm really excited about it. She's coming from UCSF, and I won't put her name out there yet because I'm not sure she wants everybody to know yet. So anyway, so she will be coming to be with us in June 2020 as we open our new center that will be a comprehensive reproductive healthcare center that will house all of our services, which are our LGBTQ services. We have a transgender clinic that has about 250 patients where we manage their hormone replacement therapy, our PrEP and PEP clinic for our HIV services, our abortion clinic, our miscarriage management clinic, and our prenatal and childbirth clinic. We are presently the only option in terms of out of hospital or hospital births for people in our community. When we decided to create this new model of care, we recognized that and decided to add midwifery service. We recognized that we needed to be sensitive to the historical harm that has happened and continues to happen to Black and Brown communities. We also recognize that access is not equal for everyone, and access is also relative. While some may say, oh, there are midwives in the community, therefore you have access. If you can't, the midwives that are in our community, first of all, there aren't that many midwives in our community, but the midwives that were in our community, home birth midwives, don't take insurance. And then there's one small hospital practice that does take insurance, and they deliver at the Safety Net Hospital. So we wanted to ensure that everyone had access to out of hospital or hospital birth if that's what they wanted, but we also wanted to make sure they had access to midwifery care as well. Next slide, please. So this is an article that was done recently about us and our new center that we're opening. We understood that, the importance of also Black midwifery to Memphis, to a predominantly Black city that had very few midwives. Presently, there are 9 certified nurse midwives. 3 of them are African American, and 2 of us work at Choices. Like I said, we are adding a 3rd certified nurse midwife, African American, in June of 2020. We understood that when we created this model, we understood the importance of using the reproductive justice framework to really guide the model and to really help us to provide care to a community that had already experienced lots of harm. We also understood that over-medicalization of Black and brown bodies, and we recognize that our reproduction is and has been constantly policed. So we understood that we were bringing care to a community that had already been traumatized, and we understood what was really important to that community was that we needed to recreate a new model of care to really disrupt the present model of care that we were experiencing in Memphis, not just in Memphis, but in this country. And what better place to do it at a clinic that was already dealing with issues that were highly stigmatized, like abortion, like transgender care. Because of course, as you all know, out-of-hospital birth is highly stigmatized also. So we wanted to make sure that we practice in a way that honored our patients, honored their lived experience, honored their bodily autonomy. And we made it a point to also invite those patients to be a part of what it is we're doing. Next slide, please. This is my new practice partner, Kamitra King. She just started at the beginning of February. She is also, she's a labor and delivery nurse for 10 years, and now she's our new certified nurse midwife. Next slide, please. So like I said, our model is grounded in the reproductive justice framework, and then we recognize that every person has the right to make reproductive health choices that meet their individual needs, whether they want to terminate a pregnancy or continue their pregnancy, and whether they want to birth out of hospital or in the hospital. Presently, I'm the only provider in our city that offers an out of hospital or in-hospital birth experience. We recognize that also that every person had a right to factual, evidence-based, unbiased information about their reproductive healthcare choices and their birthing options in order to make informed decisions, to absolutely be the leader in their care. And we also recognize that people with limited means should also have available financial resources to support access to services to meet their reproductive healthcare needs. And so one of the things that we've made sure we've done is that we do have a patient assistance fund that we raise money for every year to be able to provide care for everyone. We also wanted to make sure that we centered families that were on Medicaid, because they were the ones that really didn't have the options in terms of having out-of-hospital birth experiences. Usually with out-of-hospital births, if you didn't have cash to pay, then you usually couldn't have one. So we wanted to make sure we did our part in making it as accessible to all families as possible. Next slide. So like I said, we are building the first nonprofit comprehensive reproductive healthcare center in the country, and will also be the first birth center here in Memphis. The 16,000 square foot new facility will also provide all of our wellness care, as well as our transgender care for our transgender patients during our transgender clinic, and also have our abortion services as well. We are purposefully centering the experiences and insights of women of color, low-income women, and LGBTQ folks. We are proudly providing abortion services, prenatal care, birth services, and postpartum care, and we're addressing barriers to care. So we're working really hard to partner with community health workers, doulas, mental health professionals, lactation counselors, chiropractic care for our patients, and finding ways for them to be connected to create community in order to defragment the care that they have been experiencing. And we are working really hard to provide clinical training opportunities for student midwives of color that is grounded in the reproductive justice framework. This is really important to me because when I came on to work at Choices, one of the big asks I had was that we center Black and Brown student midwives and become a training ground for them. And so this is something that we have continued to honor and put forward. Next slide, please. So what do? We saw a gap in care that is needed, and we addressed it, right? Like I said, there are very few midwives in our community. There are maybe 5 certified professional midwives in our community. All of them are white. There are now 9 certified nurse midwives, with 3 of us being Black midwives. And the opportunities are really great in terms of providing holistic care to the Memphis community. It's truly needed here. We wanted to make all reproductive healthcare services available and affordable for all. And so we've worked really hard to raise funds. We are a 501c3, so we work really hard in writing grants and raising monies in order to provide high quality, non-judgmental care to the community. Our care is definitely patient-led and patient-centered. And we wanted to make sure we ensure continuity of care and provide families linkage to social and community services, especially the continuity of care piece was really big for us because a lot of times persons who were on TennCare or on Medicaid, what they were experiencing was that they would, if they were going to the clinics, they didn't know what provider they were going to see, and they definitely did not know who was going to be there with them when they were in labor. So we wanted to make sure we provide that constant support and truly get to know our patients and truly become family with them. And this kind of care is relationship-based care. This is not, I see you, for 10 minutes and then each month and that's it. What we're doing here is we're building a relationship. We're building a relationship based on trust and respect. And so our visits are usually 45 minutes to an hour long. And we have a really robust postpartum care where we make sure we visit the families, we make sure we keep in contact with them and make sure we get them connected to the community services that they need. But one of the other things that was really important to us also is that we honor the cultural traditions of the communities we serve. We all know that culturally competent, culturally congruent care is really important. And we wanted to make sure we honored that, especially in our community here in Memphis. But we also wanted to make sure we amplified the voices and the needs of our patients. We make sure we advocate hard for them, and we make sure we help them to learn how to advocate for themselves as well. So we are definitely creating community amongst our patients and our providers. Also, one of the really big things, like I said before, is that we're investing in training opportunities for Black birth workers. We partner with different birth workers in our community, but we also recognize that that doulas need opportunities and need opportunities to be at births and to have those things counted in order for their own certification and advancement. So those things are really important to us. Next slide, please. This is a picture of some of the wonderful families that we've gotten to serve. And like I said, we do out of hospital as well as hospital-based care. And it has been truly rewarding and a true, call to this work. And so I think my dear friend, Maya Janelle Peak, who's also a doula here in Memphis, she said that we're doing God's work. And I definitely believe that we are. Thank you.
Thank you so very much, Dr. Grayson. We really do appreciate you, and we appreciate all of the great work that you're doing at Choices. And yes, yes, indeed, you all are doing God's work. And we just give you so many praise and acknowledgement for all the great things that you all are doing in Memphis, Tennessee. Our next presenter, which will also be our last presenter for our webinar today, is Brittany True Kelman. True is the founder of Jamal Birth Village and serves as executive director. She is a mother and a wife, a certified professional midwife, certified doula and doula trainer, a breastfeeding peer counselor, and author. Through the midwifery model of care, True has seen hope restored, thriving pregnancies, healthy births, and postpartum periods. And she believes in empowered, gentle, and culturally engaged care, which she brings to practice in St. Louis, Missouri. We welcome you. Welcome, Mama True.
Everybody. Hello, Angela. Thank you. So happy to be here during Black Maternal Health Week. And it is such a humbling honor to follow behind all of our amazing panelists, Jamara and Mama Jenny and Makea. Thank you. And also just want to take a moment to honor Mama Claudia and her beautiful spirit that is with all of us here today. So I am going to be sharing just a bit with you all today. I am first a Black woman, second a mother, and third a midwife. So I'll be speaking to you all through that triple context of mostly the lived experiences that I've had, but also my skilled professional expertise, which has really helped me to understand how holistic midwifery can change our communities across the nation, and especially how it's changed my life as an individual person. So we can go to the next slide, please. So today I was asked to share with you all a bit about challenges and opportunities for Black midwives today. So we'll be talking about that and also speaking about some solutions that we can implement across the nation and how we can advocate for ourselves to keep those things going. It wouldn't do much for me to talk about how holistic midwifery has changed my life unless I gave you all just a little bit of background about how I got to where I am. I was a teen mom and I barely made it out of high school. You know, I was a community college dropout. And I went through a series of different types of trauma throughout my life, really feeling trapped in social, detriments that just kind of kept me down as a Black woman. So ultimately, I went on to have my first two children about 5 years apart. And each one of those births were at two different local hospitals, but very traumatizing. And, I was harmed in different ways. So with a passion to see past that trauma and to really reach the vision that was bestowed upon me, to see a compassionate center, like a compassionate midwifery care center for Black people, I persevered. And I ended up having my third son at home. So I had a very successful, holistic, midwife-led home birth. And then I took it a step forward and went to Africa and studied at the feet of the elder midwives there while staying in Ghana. And then when I came back to the United States of America, I made sure that I was enrolled in school and then, started my journey into being a midwife. But what I did was I began looking at the problems of my own community, but looking at it as an opportunity to create something better instead of trying to fix what, racism and bias and patriarchy has created. So I just felt like that would be like a crumbling battle, as Black women are always trying to uphold and fix what white America has done to us. So By creating that, this vision has reshaped my entire life. It has reshaped the entire maternal health landscape in the city of St. Louis, and it has greatly impacted multiple people across the world. And I'm just going to dive in now and kind of chat about how I was able to kind of navigate through that and get there. So if we look at the opportunities that are presented to us now, we are going to kind of see the setup, like where we are. So 92 to 94% of all pregnancies in the United States of America are considered low risk. So if we see that, and we also witness that 98% of those births are taking place in the hospital, we are saying that there is improper risk, there's an improper risk appropriate care mechanism that's happening. So ideally, I want to ask you all this theory, and you can put it in the chat box briefly, but if you were just going to the dentist to get your teeth cleaned, you just were going for a regular oral hygiene checkup, you didn't have any medical issues with your teeth, and you went to the dentist and asked to make an appointment, and they ask you, do you want to make an appointment with the oral hygienist, or do you want to make an appointment with the oral surgeon? Briefly, I want you all to tell me, who would you schedule your appointment with? Hygienist, okay. I see a lot of people saying the hygienist. Why would you all schedule the appointment with the hygienist instead of the oral surgeon? So I see people saying it's cheaper, less intervention, surgeon sounds scary. All of those things are true. All of those things are factual. So what that comes down to is that women who are low risk and healthy in the United States of America are being placed in the wrong level of care. So this is the setup that gives midwives the opportunity to bring the right level of care to our communities so that we can kind of shave off those interventions and shave off those complications that are unnecessary. Before we move on to the next slide, I want to highlight something that has plagued our nation since the 1920s, right around the time that the Shepard Towner Act came in, which Mama Jenny Joseph did a great job highlighting that. But around that time, there was this guy by the name of Dr. Joseph Dealey, and he wrote a medical book. And in that book, it was like the book of all times. Like everybody was reading it. It was like the Bible of obstetrics. And essentially, he created these interventive measures that this happened every single time a woman was to deliver her baby. And those interventive measures essentially made sure that every woman who came into the hospital, she was sedated, and there was some type of uterotonic to get her uterus going, and then there was some type of dilation method, and then the baby was pulled out with forceps, and then the woman had an episiotomy, and then she was sutured. And for those things that have been implemented in the 1920s by Dr. Dealey, we still see a lot of those things happening in our hospital systems today. So that's another way to kind of look at why we have some of the rates that we're having now. And we can go on to the next slide. It kind of ties into why we're going to see these percentages now and the strong opportunity that we have to stand up as birth workers. So on the left side, we see here, we have over 3 million births in the US every year. A little bit over 560,000 of those are Black births. And Black people are only making up 14% of the US population. And then if we come down and see that we have about 16.7 deaths per 100,000 live births. And we know the elevated death rate for Black women, 2 to 5 times more likely to die or be harmed, up to 12 times in New York. But one thing that I also want us to think about is that these deaths, the CDC, our own Center for Disease Control, says that 60% of those deaths are preventable. And so if we go back to that risk appropriate mechanism, we can really understand why it could have been prevented as well. So another thing that we don't talk a lot about, which is equally intense is that for every one maternal death, we're looking at 100 women who face morbidity, so some type of harm that's impacting her life. So when we think about availability, there's a vacancy for us Black midwives. We know how this void was created, but there's like really no use in crying over spilled breast milk, not just regular milk, because we know how important breast milk is. But we know that just as our milk ducts produce more and more milk for our babies, if we were to knock over, some breast milk that we pump, we have to also know that our roots are just as strong to tap back into those ducts and channel what we need to create so that we can have that force that we collectively need for Black maternal health. And what I want to highlight is that we don't need their permission. When I say there, we're talking about the 2%ers, the white leaders. We're talking about the organizations that have been dominating maternal health in our nation. We do not need their permission. We do not need their validity. We do not need their approval or their door holding. What we have to do today with the availability is do what we can until what we need shows up. So before we move off of this page, we see that there's over 11,475 nurse midwives in America. Mama Jenny did a great job highlighting the differences between midwives and how that credential even came to be. We're seeing that 1 in 9 midwives in America are CPMs, only 2% and slowly rising of all midwives are Black. The bigger disparity is the spaces where Black people feel safe and have access to give birth in. So we see that there are over 345 freestanding birth centers in America, but less than 15 of those are Black owned and ran. So when we think about Black women being at a greater risk due to implicit bias, systemic racism, social determinants of health, all the things that Jamara did a great job explaining, we realize that it is up to us Black midwives and birth workers to not only implement those direct levels of care that we have, like I'm a midwife, so I'm just doing your prenatal, postpartum care, do your home birth. I'm a doula, I'm just showing up at the hospital, got my bag, doing your birth plan. No, like it's not time to just do that. We have to provide holistic wraparound care services so that we're able to address these core maternal health issues that span out in multiple sectors. So we can go to the next slide, please. So many of you know who may follow me, or you may have heard my name, or you may just not be meeting me. But in 2019, I did become Missouri's first Black CPM. And it was literally the hardest journey ever because I stood on racist grounds. And that is a challenge that we face as Black midwives across the planet, not just in America. So in order for me to get accepted to school, get a scholarship, be on call while trying to be employed and still care for my family, while dealing with racist preceptors that did more to stunt my growth and development than to actually develop my skills, of having to deal with biased exams and also going through imposter syndrome because of all of those things. Those were different things that really kind of challenged me into becoming a Black midwife. But how I got through it was really creating fertile ground for my own growth. So not adhering to the different ways of how our racist system tries to steer us, and really creating a way that worked for me as a Black woman. So if we go to the next slide, we're going to talk about what racist grounds look like and what challenges we face as Black midwives in America. So first, we deal with issues with licensing and regulation. So we have fear of persecution in states where we're unlicensed. If we see here, as of October 1st, 2019, 35 states licensed midwives in America. I live in Missouri, where midwifery is unregulated, but we are legal. But in certain states like this, we have the inability to use certain life-saving medications within our scope because of this really rigid system that we're in. And then if we think about how the challenges that we face as Black midwives caring for our community, We have birth center laws that are very racist and structured in power. So many states don't allow birth centers to be ran by certified professional midwives. It has to be physician or nurse midwife oversight so that it's connected to the hospital. And so another issue is that we don't have the ability to bill Medicaid, and a lot of our families need that option and care. So finally, one of the challenges that Black midwives are facing right now is burnout. So just really dealing with the crisis, the maternal health crisis, which is so thick that oftentimes we forget to save ourselves in the process. And people who follow me on Facebook see a lot of how I post about reading or going outside or taking time off. And it's okay to plan financially to take a break for a month, or to have a 3 or 4 day work week instead of working 6 or 7 days a week and not spending time with our family. It's okay to take a light client load because we may be the only midwife and we may not have a partner. So it's okay to not try to do it all. So we can go to the next slide. So in me starting with what I had to get to where I really felt like our community wanted to be, I created True's Community Midwife Model of Care in 2015. And it's the current model of care that Jama Birth Village uses in Ferguson, Missouri. So with this model of care, it's a licensed model that has the ability to reshape communities that have a void of Black midwifery in their spaces. So this first sector here is having a non-for-profit clinic. So students will remain in their communities instead of going to the suburbs as the help, and I'm quoting my fingers if I could see you all, and with the possibility of being re-traumatized. So a lot of Black midwifery students don't have Black preceptors in their area. So they have to move across state lines, leave their families, or go to different cities to study under white midwives and their white clients who may not have cultural sensitivity and who, you know, and we end up being re-traumatized and going through a lot while trying to become midwives. So under this particular model, instead of that happening, we have white allied midwives who are culturally congruent, who are trained in trauma sensitivity, and they come into our communities to precept us in our spaces so that we're not removing the gold that we need to save our families. So in the second phase of this model, while students are practicing and learning how to be a midwife, they are also learning how to operate a midwifery clinic. And in that sense, they're also focused on community building. So learning about the resources in the area, providing donations, diapers, wipes, mother-baby clothes, providing education, childbirth, parenting, providing classes and workshops, but also being a safety place, a safety net where heritage and culture can be celebrated instead of it being an afterthought. So in the third phase of this particular model, the student graduates, becomes a midwife, and phases, and this clinic now phases into a birth center that's still in that neighborhood. So throughout this entire process, this Black woman can stay in her home with her family, in her community, serve her community, learn more about her community, learn how to be a midwife in her community with her people instead of being removed and having to come back and reacclimate. And then she's able to now be able to allow her community members to stay in their communities and give birth right there, not too far from their homes. So what we are doing with this model as well is putting spirit back into the community instead of having to remove our physical bodies when we're birthing new generations and putting them into institutions that have historically harmed us, wanted to see us without, and taken away from us. We're giving them that energy. So with this model, we're able to restore spirit and heal trauma and heal pain. So if we can go on to the next slide, please. So finally, we're at our last place where we're talking about advocacy. So thinking about moving on from here, because all of us are in a different place on this call. Some of us are birth workers, some of us are midwives, some of us are social workers or just community people. Some of us are of color, some of us are not. No matter where you fit, think about your vision and think about the vision for your community and hold tight to it and don't waver from the core of that vision so that you can advocate for yourself and get through it. And then perseverance. You will be challenged. So what we want to do is intensely persevere so that we can truly arrive at this culmination of what Black maternal health means for all of us and what maternal health equity means for all of us. And then finally, we are going to triumph, because if you have a vision that you are not moving away from and you're standing on fertile ground, and if you persevere every time racism and bias tries to knock you down, you have no choice but to triumph. And you all have seen me over and over again do this. And so because we are creating something, creating what we had and more, all we can do is win. So we're going to go to the next slide. And I want to thank you all for having me here for Black Maternal Health Week and allowing me to share and be amongst your presence. And I look forward to connecting with you. Follow us and let's get it. Let's keep saving our moms and babies.
That's right. Thank you so very much, True. We really do appreciate that. What a powerful, powerful presentation. And what a powerful presentation from all of our presenters today. Thank you so much for lending your time and your expertise. And I have to say that again. Thank y'all so very much for lending your time, because every midwife that spoke today, they are still practicing and seeing patients today. So I have to thank y'all for your time. And I hope that everybody that's still on this webinar, please give them all a shout out and thank them for their time and their expertise on today's webinar. Please note that all presenters will remain on the webinar until the close to answer questions through the chat box. And before we go to the Q&A portion, I'd like to highlight the following announcements. Be sure to join us for our last webinar, Centering Black Mamas to Live and Thrive in Practice. That webinar as well will be held tomorrow. It will also start at 2 p.m. Again, the registration link can be found on our website at blackmamasmatter.org. And then also just note that all webinars that we've held throughout this week will be available on our website soon. I will now turn it over to Rose Aka-James, who is our National Membership Manager, who will be fielding questions from our chat box to our presenters. Rose?
Thank you, Angela, and thank you to all our incredible midwives for their presentations. It's just always fulfilling and just incredible to see all the work that you're doing for Black mamas across the country. We're going to take about 4 or 5 questions. I see some that are coming through the chat box. There's been some that have come through the Q&A section. So I'll start with the question I think is geared towards Midwife Jamara. Somebody asks, where are the Bill of Rights located?
Thank you. The Bill of Rights, the Birth Justice Bill of Rights is located at southernbirthjustice.org. Again, southernbirthjustice.org. It's right there on the homepage, and you can click on Birth Justice Bill of Rights. There is one document that was the one that was in the presentation that outlines the Bill of Rights, and then there's a second document that goes into more detail about each right and why it's important.
Thank you, Jamara. The next question is for Dr. Grayson. It says, how does Choices manage the public policy and health justice?
Repeat the question for me.
Yes, the question is, how does Choices manage public policy and health justice?
I'm trying to make sure I don't get feedback over here. Hold on a second.
No problem.
Okay. So how do we manage
Public
health
policy and health justice issues.
Yeah, that's a good question. We have a great team of lawyers. No, we also, the policy issues that we face in Memphis usually are around our abortion care. And so we have a 501c4 here that's called Healthy and Free Tennessee that helps us with lobbying and advocating for the reproductive rights that we're fighting for. We also have a program even at the clinic where we are really working to help educate patients about advocacy. So we do a really big piece on patients to advocates, where we really help them to learn how to tell their own story and help us to craft public policies that are in their favor. I think that's one of the hardest things being in a red state, is really dealing with the legislation around, like I said, abortion access. But we recognize also that the barriers that our patients were facing in terms of abortion are also the barriers they face in terms of accessing midwifery care and really exercising their birth options. So we really try to do a lot of education. We partner with different local advocacy groups, and we work with our 501c4.
Thank you, Dr. Grayson. The next question, I guess anybody can answer this. Attendee wants to know, has the Affordable Care Act made a difference in access to midwifery care?
This is Makea. No, it hasn't. I would say that in Tennessee, reimbursement, and someone asked about this, I think Alexandra asked about reimbursement and asked if it covered our services. The answer is no. Our TennCare reimbursement is extremely low. Tennessee is one of the states that did not take the Medicaid expansion money, and so no, the reimbursement does not really cover all of the costs that we incur in bringing care, midwifery care to our community. One of the things we did was we knew right away that was going to be one of the issues, and we really used other services to kind of offset those costs that we really do incur.
Thank you, Dr. Grayson. Would anybody else like to add on to that?
This is Jamara. I am in Florida, which is a state where midwifery services, out of hospital birth center services, home birth, and birth centers are required by law to be covered by private insurances and Medicaid. And so the expansion of affordable health care does mean that more people can be covered. However, we're in a state as well where Medicaid expansion didn't happen. And so that is still a huge barrier for people getting their costs covered. So there has been some benefit to some families that have access to health insurance coverage that didn't before, but we still have hundreds of thousands of families that don't have access because there has been no Medicaid expansion, which is why we need universal health care.
Thank you, Jamara. Our last question for today, attendee asks, as a white doula practicing in an area with a rich, historically Black community, what is the first step I can take to leverage my privilege and advocate for my sisters of color?
This is true. I'm very happy that you joined for the webinar today, and also that you're aware of like privilege and wanting to be an ally in your community. Personally, just from working with different allies in my community, I always encourage them to have their first step be their own internal and personal work. So before we necessarily want to physically be an ally or support in culturally rich, Black communities, especially surrounding birth, we first want to make sure that we are aware of what our bias is outside of what privilege is, how our biases shows up, what are our triggers, and really dissecting that and eliminating it and being honest and aware of it. One of the quickest things that you can do while you're working on those things is to find those grassroots community-based organizations that are doing work for maternal health in your community and financially invest in that. And while you're working on your internal work as a white privileged person, try to do more work from afar until you do that personal work, so that we don't make sure that we're not doing re-traumatizing of people, and to also make sure that you don't fall into a white saviorism or a tokenizing approach where it's more about what am I doing for the people versus how am I supporting and leveraging. And the last thing that I would just like to offer up is that if and when you do dissect your bias and all of those things that are inherently, in white people, once you do those things, just make sure that you're open to getting feedback from people about like behavior and different things of that nature. So, yeah.
Thank you so much, Drew, for that full, thorough answer. That's all the time we have today for our Q&A session. As a reminder, we will all webinars are being recorded, and so you will have access to them after Black Maternal Health Week. They'll be posted on our website. We ask that if you do use any of our presenters' work or presentations in your own work or in your teaching, make sure that you are definitely citing the original work of these incredible midwives and all the folks who have been on our webinars. We take people's intellectual property very seriously, and so we just ask that you do the same. Again, thank you so much to our presenters. I'm going to turn it back over to Angela.
Thank you so much, Rose. We hope you gained a new understanding of improving health outcomes for Black mamas through holistic midwifery care by attending this webinar, and will use this knowledge in your daily work to become champions of Black maternal health rights and justice. You can continue to engage with us throughout the Black Maternal Health Week campaign by following us on all of our social media platforms and through the hashtag BMHW20. Visit our website for additional information about the Black Mamas Matter Alliance, and you can sign up for our newsletter and be involved in our initiatives through signing up for that newsletter. With sincere gratitude for your attendance to today's webinar, thank you all so much, and do have a good one, and please continue to be safe. Thank you.